Hello, everyone, and welcome to today's edition of Podcast. Today is May 19th, 2020. Hope you all are staying safe with your loved ones. Hello, everyone, and welcome to today's edition of in Philadelphia, and I am remotely joined today by my May 19th, friend, 2020, Emilio Madrigal, who is hope in you Boston. All are staying safe with your loved ones. We are very excited to welcome our speaker from Australia, Dr. Catriona McKenzie. She's a senior staff specialist at Royal Prince Alfred Hospital in Sydney and also an associate professor of pathology at University of Sydney. Today, over the next 1 hour, she is going to present a lecture on liver pathology, which is titled Liver Pathology Masterclass, Mistakes Made and Lessons Learned. As always, please feel free to post your questions and comments on both YouTube and Facebook chat windows, and Dr. McKenzie will answer them towards the end of the session. Thank you, Dr. McKenzie, for your effort and staying late. It must be around 10 p.m. in Sydney for you. We appreciate it so much, and thanks for joining us. Over to you now, Dr. McKenzie.
Okay. Thanks so much for inviting me to speak about liver pathology, which has to be one of my favourite areas in pathology. So as Rafat kindly introduced me, I'm a senior staff specialist at Royal Prince Alfred Hospital, which is situated here on the east coast of Australia. And Royal Prince Alfred Hospital is a large teaching hospital and receives the most liver transplants in Australia. So we've seen a lot of interesting pathology over the years. And we're right next door here, as you can see to the map, to Sydney University, where I also work as an associate professor. So what I wanted to do in this lecture tonight was outline a systematic approach to medical liver biopsies using examples from our practice, highlighting some pitfalls and practical teaching points that I've learned over the last decade or so while working at Prince Alfred. And I think, one of my other passions is medical education, and something I really want to highlight, particularly for residents, is the importance of thinking like a physician in medical liver. And then briefly just consider how our role as pathologists is changing in medical liver in this new era of personalised medicine and with some new drug treatments coming out. So as I said, I have a very systematic approach to these livers, starting with clinical history and serology, then moving to the H&E, looking at low power at the architecture, then moving to high power to look at the portal tracts, the acini, the central veins, the sinusoids, and then of course the special stains and ancillary studies. So before presenting the first case, I found this article quite interesting in the Archives of Pathology and Laboratory Medicine. We often put in the comment clinico-pathological correlation is recommended, but the question I think we have to ask ourselves is who should correlate and when? And I agree with these authors who say it's our responsibility as pathologists to obtain clinical information when it's not there. And I think nowhere is this more true than in medical liver. So this first case, this is quite a typical clinical history, or perhaps you might say it's not even a clinical history so much as a statement of sight that we're given for these cases. So we're told it's a liver biopsy from a 47-year-old woman, nothing else. At low power, the liver has a relatively preserved architecture with just a little bit of portal tract inflammation visible. What do I mean by normal architecture? What I like to see is that the portal tracts and central veins are present at regular intervals throughout the liver, and the trabeculae are 1 to 2 cells thick, or another way of looking at this is that no more than that all the hepatocytes are touching the reticulin framework of the liver. And normal architecture, I think also you don't want to see any significant fibrosis. So looking more closely at this case in the portal tract region, some looked quite normal, but some did contain a mild chronic inflammatory cell infiltrate, which brings me to my first, I guess, checkpoint list, the things you should think about with mild portal inflammation, which include hepatitis B and C, drugs, autoimmune, and some mimics, which I'll touch on, mimics of chronic hepatitis that I'll touch on later. So looking more closely in the hepatic parenchyma, can see that the hepatocytes, in fact, have this quite nice ground glass change. And if you've ever wondered what ground glass is, it in fact refers to this sort of glass whose surface has been ground to produce a flat but rough finish, which can be both decorative or used in things such as laboratory glass bottles. What are the differential diagnoses that should be considered? The more common causes of this cytoplasmic ground glass change, of course, hepatitis B, can also be seen in glycogenic hepatopathy and glycogen pseudo-ground glass inclusions. There are some rarer causes, which I have to admit, including Lafora's disease, are still very much on my pathology bucket list. And if ever anyone sees any of these, I'd love to see them. Something else, people who, if you see a reasonable number of livers, you might have noticed is this strange sort of two-toned appearance in the hepatocytes. And, you know, in these near normal livers, this can be a hint of a drug reaction as described by Torbenson as an adaptive response to some of these medications. But anyway, coming back to our case, common things are of course common, and with that mild portal tract inflammation and strong positive porcine staining, the diagnosis is of course hepatitis B infection. So hepatitis B is still a significant problem worldwide, although less than 5% of patients develop a chronic infection. This still equates to 250 million people, about 30% of whom will develop cirrhosis, which equates to nearly 900,000 deaths per year. The new antiviral treatments that are available for Hep B delay cirrhosis and reduce the incidence of cancer, but compared to Hep C, they are lifelong treatments. So, you know, a significant expense. So something I guess I also wanted to highlight to this case is that we used to see a lot of biopsies in practice for hepatitis B and C, but the landscape of biopsies, or perhaps I should say the epidemiology of liver disease, is changing with the rise of ASH and NASH. And in major transplant centres now, hepatitis B actually represents a relatively small number of cases transplanted. So I think the learning points for this case are that the liver is rarely biopsied for no reason, and that you know, there are a few differential diagnoses to keep in mind if you see mild portal inflammation and also some ground glass cytoplasmic change. And also, I think the other issue I guess I wanted to raise was that staging biopsies for viral hepatitis, certainly in our laboratory, are no longer routinely done. And what we're seeing now is more and more of these difficult cases with more than one pathology or potential etiology, which are becoming increasingly routine, such as this next case, which is that of a 54-year-old woman. So we're actually given quite a good history here of increasing LFTs with 3 possible etiologies proposed: fatty liver disease, primary biliary cirrhosis, as the patient had a strong positive AMA, or drug-induced liver injury, with methotrexate being the drug potentially implicated. These are her LFTs, which show a strong, you know, a cholestatic pattern of injury. And she did indeed have a strong positive AMA titer, which are consistent with, but as you may know, not entirely diagnostic of primary biliary cirrhosis. It is important, I think, to note that these antibodies can predict future liver disease in patients if they're picked up on screening. So I think, you know, in terms of those 3 potential etiologies, we can immediately rule out non-alcoholic fatty liver disease with the complete absence of fat. But what I'm sure you can appreciate at lower power here is these portal-based granulomas, shown more closely here with some quite obvious duct damage. pictured again here. And in some areas, the inflammation in the portal tracts is quite dense, obscuring the bile ducts altogether, and a few small lobular granulomas were also identified. Not much, no significant fibrosis. So PBC is one of the main causes of granulomas in the liver, but it's also known that in a small percentage of cases drugs are implicated. And so I found it helpful in these cases where you may have a drug implicated in the etiology of the liver disease to check the liver tox website to see if the drug in question has caused this pattern of injury. And methotrexate is much more strongly associated with fatty liver and fibrosis, making it an unlikely causative agent in this particular scenario. And adding weight to this evidence, while ANA as an autoantibody is not uncommonly seen in DILI in this series up to sort of 44% of cases, a positive AMA titer is actually relatively rare in drug-induced liver disease. So putting it all together, this is consistent with primary biliary cholangitis, and sometimes in our referral cases, I still see it referred to as primary biliary cirrhosis, but the name indeed was formally changed a few years ago, as many of these patients don't, of course, end up developing cirrhosis. Our patient was very typical in terms of demographic, being a middle-aged female with positive AMA. IgM can also be elevated. Important to know that ANA, and I'll talk a little bit more about ANA, can be positive in up to 50% of cases. And in fact, over 60 autoantibodies have been described in PBC. So to summarize case 2, PBC, it's the same acronym, but has had a name change in the last few years. Very important to interpret autoantibodies in context in all these liver cases. And while AMA is relatively specific, I personally regard ANA as the Vimentin of autoantibodies that can be positive in a number of liver conditions. And I find the NIH website very helpful when assessing these cases with multiple potential etiologies to see if the drug in question has caused a particular pattern of liver injury. This next case is an example of acute hepatitis. And again, this is a common scenario we get in our practice, which can be sometimes a bit difficult to sort out. So 57-year-old woman, query autoimmune hepatitis. You can see at low power straight away that there is some quite obvious liver damage with areas of necrosis, as well as some portal-based inflammation, which I'll go to higher power shortly. We have areas of portal-portal and portal-central bridging necrosis. This picture here being of our beautiful harbour bridge in Sydney. An issue we see in consult practice sometimes is I think it can be difficult to distinguish necrosis from cirrhosis in biopsies, or sometimes cirrhosis is overcalled. And something that's very helpful is the reticulin staining pattern in these necrotic cases. In areas of necrosis. Here you can see the collapse of the reticulin framework compared to cirrhosis, where you have this much more dense, closely packed reticulin fibres here. Also, the trichrome stain. I use as an internal control the collagen layer around ducts and in the portal tracts, and you can see in these areas of necrosis that it's really this it has this fluffy pale blue appearance rather than the dense appearance you see in true fibrosis. So important not to overcall this in these cases. Always important to check for the presence of the interlobular bile ducts, which were there with some appearing a little damaged. Inflammatory infiltrate in the portal tracts is you can see it's quite dense with scattered plasma cells present. Quite marked perivenulitis, with some perivenular necrosis, as well as quite substantial lobular disarray with inflammation and scattered apoptotic hepatocytes. So when you have this pattern of an acute hepatitis with prominent lobular inflammation and disarray, I think the three main diagnoses to consider are viral, autoimmune, and drug-induced hepatitis. And the comment I put in this particular case was that, you know, the appearances of those of an acute severe hepatitis with areas of bridging and confluence necrosis, and that if viral serology is negative and drugs and toxins have been excluded, the appearances could be consistent with autoimmune hepatitis, and that, you know, correlation with clinical and serological findings is required. Having emphasised the importance of clinico-pathological correlation, I clearly hadn't done it in this case, because when I looked up the auto antibodies, they were in fact negative, and IgG was also not raised. So these are difficult cases, and they seem to come up quite often. The question being, is this seronegative autoimmune hepatitis? So this is a difficult entity, I think, but it's thought that approximately, you know, 7% of patients with acute presentations of hepatitis may represent this entity. The diagnostic criteria, you know, say in the literature at least that they have a similar clinical presentation and diagnostic criteria to autoimmune hepatitis, including exclusion of other diseases, but the conventional antibodies are negative, as well as some of the rarer antibodies, and they may or may not have hypergammaglobulinemia and elevated IgG levels. So, you know, what are these cases really? You know, it's possible that there may be unknown or non-conventional antibodies or host factors in some cases. It's possible that some cases represent DILI, or it's even possible that some may represent unrecognised viral infections. I think the good news, I guess, for pathologists is that, you know, when you have this pattern of injury, steroids should probably be considered regardless if the patient's not getting better, as a significant percentage will respond to steroids, whether or not it's drug-induced liver injury with its pattern or true autoimmune hepatitis. Coming back to our patient, they clearly had read my report and weaned her off prednisone over 6 months or so, and her LFTs normalised, and a final diagnosis of drug-induced liver injury was made. There are a large number of supplements available over the counter that can cause drug-induced liver injury, and we've had cases recently due to green tea extract and Garcinia cambogia, both of which are weight loss agents. Of course, it's not always herbal or illicit drugs that cause this, but it's also been very well described in some drugs, particularly more recently the immune checkpoint inhibitors. And this is a case we wrote up a couple of years ago, secondary to pembrolizumab, that had, you know, quite a similar appearance to the case I just presented. So I think what I've learned over the years is the distinction between autoimmune hepatitis and drug-induced liver injury is difficult histologically, and sometimes it's only time and clinical course that makes the diagnosis. But I think given that autoimmune hepatitis can be seronegative, that autoantibodies can be positive in drug-induced liver injury, particularly ANA, and some drugs such as, you know, nitrofurantoin can trigger self-perpetuating autoimmune hepatitis. It's certainly not unreasonable to keep your bottom line open. And while we're talking about acute hepatitis, in case you're wondering, COVID-19, I noticed this on Twitter, has been associated with some acute hepatitis. And this is just a tweet conversation I had with John Hart. And quite recently, these have been written up with descriptions of an acute hepatitis in cases of COVID-19. So moving along, after clinical history, serology, this low power assessment, looking at the overall architecture, the next thing I always focus on in detail are the portal tracts. So this next case is of a, it differs in the clinical history and the power chart, but a 24 or 25-year-old woman, again, very unhelpful history, slide review for our multidisciplinary meeting. So in assessing portal tracts, I think there are some rules to live by. The interlobular bile duct should be the same size as the arteriole and approximately 1 to 2 diameters away from it. The portal vein should be 4 to 5 times of the artery, and the amount of fibrous tissue should be roughly proportionate to the size of the portal tract. So in larger tracts, of course, you have more fibrosis. So again, important not to overcall this as fibrosis. So this is this young woman's liver biopsy. Again, you can see at low power, it has a relatively normal looking hepatic architecture, no obvious fibrosis. The abnormality, of course, is in the bile duct, in the portal tract regions. You can see that the hepatic vein and artery are present, but the bile ducts are absent. And in fact, on the CK7 stain in the course submitted, no bile ducts were present. But what you can see is this increased staining of periportal hepatocytes in keeping with a chronic cholestatic disorder. So on further history, this poor woman had been diagnosed with PBC 10 years ago based on some abnormal liver biochemistry and a biopsy that was done at a small peripheral centre. She represented to the liver unit with disabling refractory pruritus and shortness of breath. In retrospect, there were some red flags, including the fact that her AMA is negative. As you recall, in that previous case, 95% of cases are positive. It's pretty unusual to get PBC in a patient of this age, and also her liver biopsy had been reported as normal, although when subsequently reviewed, there was some signs of duct loss. And this, in fact, is an example of an entity that's very rare to present in adults, of Alagille syndrome, which has been subsequently mapped to chromosome 20, and this patient had one of the characteristic mutations. This isn't a patient, it's a photo from the internet, but they do have this characteristic face as well, facial features as well, which was picked up by the clinician, and she was sent for molecular testing. So again, I've talked about before, but these almost normal liver biopsies are tricky, and I think there's a few things to keep in mind, including resolving acute hepatitis, where you've sort of missed the bus, if you like, and the only clue remaining is some Kupffer cells, amyloid, NRH, vitamin A excess, and these vanishing bile duct syndromes. And I often add a CK7 and amyloid stain to these cases that look close to normal. This is a textbook list of causes of ductopenia, which I won't read out, except to comment that I think our understanding of entities that were considered idiopathic previously is expanding, and these adult onset of genetic bile acid transport defects is now quite well described, and this is a nice review by some of my colleagues in Queensland on this issue. And this is another case we had of vanishing bile ducts in a 29-year-old man, possibly due to augmentin, but they're also considering doing, advanced molecular testing to see if he has one of these bile acid transport type defects. Just a little bit more on bile ducts. This next case is a patient where we're given the history of PSC, and the question was in fact whether the patient had cholangiocarcinoma. This is his liver resection, and no cholangiocarcinoma was identified on multiple sections, although he did have these this quite striking cholelithiasis. PSC is a disease generally involving large ducts, and this is one of the larger ducts near the hilum, or sorry, I should say, where you'd expect the duct to see the duct adjacent to the artery, but instead have a large fibrous portal scar. When you get core biopsies of these, you may not in fact see very much, because it is, as I said, a large duct disease and can be quite patchy. So it's nice in this case to see the spectrum of duct changes out in the peripheral liver. And here you can see the nice concentric fibrosis and varying degrees of duct damage through to these scars where no duct at all is evident. Demographics very typical in this case. In contrast to PBC, it's more common in men. There are no specific autoantibodies. It is strongly associated, of course, with inflammatory bowel disease, particularly ulcerative colitis. The brief points I wanted to raise to this is, firstly, I think we see, again, in some of these review cases, a bit of perhaps overcalling of onion skinning fibrosis. There is normally quite a dense concentric layer of collagen around bile ducts. To call something onion skinning or periductal fibrosis, I like to see this looser, more edematous look to the periductal fibrosis, and of course the presence of duct damage. Another issue that arises quite frequently is the diagnosis of overlap syndromes. And, this is a difficult area, and I've asked several, quite a number of very good pathologists over the years, their approach, and probably the best one or the summary that I like best is from Professor Misraji, who says, you should consider an overlap syndrome when you see a war against hepatocytes and bile ducts. So you really want to see florid changes of both before calling it but it is a difficult area. And as I said previously, the changes, it is a disease of large ducts. So if you have needle biopsies, the changes can be quite subtle. So clinico-pathological correlation is again vital. And as I said in that previous case, a cytokeratin 7 stain can be very helpful in assessing these cases. So moving now to some of the changes you see out in the parenchyma or lobules, if you prefer. It'd be hard to have a discussion of medical liver without talking about fat. So this next case is an interesting case of a 25-year-old woman. Again, the history was fairly brief, particularly when we've of course got the true story. So the I guess more detailed history was that she'd been transferred to Prince Alfred in acute liver failure. She had a complex social and psychiatric history with a history of excess cannabis use, but no history of alcohol intake. She had, interestingly, 37 kilograms of weight loss in the last 8 months. I've realised I perhaps should have converted that to pounds. I think it's roughly double, so maybe 80 or 90 pounds of weight loss in the last 8 months, from 90 down to 53 kilograms. There's a question of an excess dose of paracetamol, although on closer questioning this wasn't found to be the case, and all her serology was negative. At low power, you can see what's obviously a very fatty liver, with some fibrosis evident on H&E. Portal tract regions show the presence of ducts and no significant inflammation. Looking more closely out in the liver itself, there's obvious ballooning present in multiple sections. And again, for any residents who listen to this, to distinguish ballooning from macrovesicular steatosis. Macrovesicular steatosis, we like to see a large droplet of fat pushing the nucleus to the side, whereas in ballooning, the nucleus remains relatively central, and you get this characteristic change in the cytoplasm. As I said, you can see the fibrosis on H and E. This trichrome's a little pale, but again, I think you can appreciate that there's really quite marked zone 3 pericellular fibrosis. And another feature was some quite marked cholestasis. So, it's steatohepatitis. Is it alcoholic steatohepatitis? The patient had no history of alcohol ingestion. Is it NASH? Is it NASH with some other, compounding or additional insults such as drugs? Or is it, some other cause of steatohepatitis altogether? And what we actually think this case is a variant of NASH that's been described following rapid weight loss or malnutrition. As I'm sure you all know, NASH is really typically quite an insidious, long-standing disease. So it's pretty uncommon for it to present in acute liver failure. And in these cases described in the literature, the patients all had rapid weight loss 4 after Roux-en-Y gastric bypass procedures and 2 after starvation-like dieting, such as this patient. And they all had these advanced alcoholic steatohepatitis-like features. And it's thought perhaps that rapid fat mobilization in obese patients may potentially lead to oxidative stress in the liver, causing this pattern of injury. As you may be aware, we're in the middle of what the Lancet describes as a global syndemic, which is a term alluding to parallel epidemics in obesity, undernutrition, and climate change. I guess we can also add a pandemic in there too now. And so for the first time, probably in human history, overnutrition has overtaken undernutrition as a cause of malnutrition. What's the role of these pathologists in the pathologists in these biopsies? Again, I think practice has changed over the last 20 years, certainly since I trained as a pathologist. We are asked to grade these periodically and stage the degree of fibrosis, principally for clinical trials to assess suitability for some of the drugs that are in development. But just draw your attention briefly to grading of steatosis. So we are regarded as the gold standard in fatty liver disease, and also for assessing donor livers for assessing macrovesicular steatosis in livers. And we use the 4-tiered staging system, as I alluded to in the previous slide, where less than 5% is considered normal, and then it's divided into thirds. So I must say I was a little disturbed when I was asked to take part in this Banff study, in which 59 pathologists graded liver cases for macrovesicular steatosis. And if you look, for example, at case 3, you can see that the same case was actually called normal, mild, moderate, or severe. So this is, one case by different pathologists around the world. I'd like to thank Desley Neal from Birmingham for giving me permission to use this slide. And I think, there's been different methods used to quantify fat, but I think we probably generally tend to overestimate fat in the liver a bit. And I know I certainly did, or I think I did, retrospectively looking in this study. And it's been suggested by some that we should use these these visual charts to more reliably assess fat in the liver. Another issue is the presence of autoantibodies in NAFLD. As I said, I see ANA a bit like the dimension of autoantibodies, and it's been described in up to 40% of NAFLD cases in some series, and other antibodies have also been described, including ANA, but in a really small percentage of cases. Just a final comment on fat in the liver is that microvesicular steatosis is different from small droplet fat. It is in fact in itself a very rare diagnosis in which you see numerous small droplets of fat in the cytoplasm with a central nucleus. And this is an example here from a case we had a few years back of a woman with acute fatty liver of pregnancy. It's a diffuse process, and it's associated with drugs, toxins, and some rare inherited disorders causing mitochondrial injury. But it can coexist in alcoholic liver disease in small amounts. So to summarise the learning points from this case, as this probably isn't new, this of course isn't news, but NAFLD is an increasing health burden globally. And in addition to grading and staging, which I guess we may not do very well, pathologists are increasingly being asked to referee some of these difficult cases with dual diagnoses or atypical clinical presentations. So I thought this was a nice example of this aggressive case or variant of NASH. It was good to be aware of, and again a reminder that it's important to be cautious in your interpretation of autoantibodies in these medical liver cases. So this next case is again an unusual variant of fat in the liver. Again, a bit of a sketchy clinical history, 40-year-old with known cirrhosis, we're told. At low power, you can see it's a bit of an unusual pattern of fibrosis here on the reticulum and trichrome, with this irregular, pattern seen. On higher power, she's obviously steatotic, and you can see a bit of action around the portal tracts, which I'll focus on shortly. So marked steatosis, as well as some ballooning and quite pronounced cholestasis. So this is one of the portal tract regions with marked ductular proliferation, in which you can see this really quite inspissated or dense-looking bile pictured again here, which had an unusual feature being strongly positive for PAS. And so while alcoholic and non-alcoholic fatty liver disease and of course drugs are the leading causes of steatohepatitis and steatosis, there are a number of other causes, including nutritional causes, and another one which is quite rare, so I thought it was nice to put this example up, is cystic fibrosis, which can present with steatohepatitis, marked cholestasis with these bile plugs showing PAS positivity, and the patients do much worse compared to patients with no liver disease. So like, acute hepatitis, steatohepatitis is a pattern of injury, and whilst most cases are due to alcoholic or non-alcoholic fatty liver disease, it's good to keep your bottom line open if there's no clinical history or you have an atypical pattern of injury. So this next case is again one of these complex cases with multiple possible etiologies. So in this case, we're told 24-year-old woman, 2 years of deranged LFTs, known to have diabetes and celiac disease. Is this autoimmune hepatitis? And the reason they were querying this in part is because she had a strong ANA titer of 640. Her TTG was also positive, in keeping with her known celiac disease. So looking at the liver, I think, even at low power, you can see that there's quite a marked abnormality in the hepatocytes with this expansion of their cytoplasm shown more closely here. This material is strongly PAS positive and DIPAS and removed by DIPAS, consistent with glycogenic hepatopathy. What I guess complicated the case a little more was the presence in some portal tracts of some relatively mild portal-based inflammation. So as I said, we've got positive autoantibodies, history of celiac disease, history of diabetes as potential contributors to liver injury. So in glycogenic hepatopathy, you can in fact get some mild portal inflammation, which may be the cause in this case, but something you may not realise or is not I guess that often discussed is that the celiac disease can also cause liver disease and may present with some portal-based inflammation, and the liver function tests in these patients do in fact respond to a gluten-free diet. The question again with the strong positive ANA and a history of autoimmune diseases is could this be autoimmune liver disease? I don't, again, these scoring systems are often developed for research studies, but I do find it helpful sometimes to, apply the criteria in these more complex cases. And, if you want to apply the scores, she does have autoantibodies, but she didn't have any IgG positivity. I would say, her liver histology is not compatible with autoimmune hepatitis, given the mildness of the portal infiltrate and lack of significant interface activity. And she didn't have viral hepatitis. So she doesn't really, make the criteria if you were to apply them. But, it is a concern because if you miss autoimmune hepatitis, these patients, can progress quite rapidly to cirrhosis. In any case, in this woman, I signed it out as glycogenic hepatopathy with a possible second etiology, with celiac disease being more likely than autoimmune hepatitis. On follow-up, she remains non-compliant with her gluten-free diet, and she also has control of her blood sugars. So I think, the diagnosis remains valid, and her LFTs remain at most mildly elevated, making autoimmune hepatitis unlikely. So moving now away from the hepatic parenchyma to some of the vascular lesions in the liver. I think these are a very difficult area in the liver. Obstruction to vascular flow can involve large vessels, right up to the heart, central veins and sinusoids. And this pattern can lead to nodular regenerative hyperplasia. So I've got pictured here on the right a typical example of vascular outflow obstruction with this marked sinusoidal dilatation and hepatocyte atrophy. Another example here is this patient who was on chemotherapy with Volfox, used often in colorectal cancer patients. And you can see here at low power this nodularity of the liver with zone 3 sinusoidal dilatation. And the case I want to present is of a 33-year-old woman where we were given the history of cystinosis and also of cirrhosis, query cause. So on low power, the liver clearly, isn't cirrhotic, but I think you can appreciate this vague sense of nodularity in the liver, shown again here on the H and E. It's better seen on the reticulum with this compression of hepatocytes at the periphery of one of the nodules, and variation in hepatocyte size. And again, here you can see some hepatocyte atrophy and sinusoidal dilatation. Looking more closely in the sinusoids, they were packed, many of them, with these Kupffer cells containing this finely granular material pictured again here. And this, in fact, is a case of cystinosis causing non-cirrhotic portal hypertension which is one of the synonyms or terms used for nodular regenerative hyperplasia. And this pattern of injury is thought to be secondary to cysteine accumulation in Kupffer cells blocking the sinusoids. I think diagnosing NRH is difficult. This study looking at inter-observer variability, not surprisingly, found it to be quite poor, but using some modified criteria, which I'll show you on the next slide, and excluding suboptimal biopsies, they did get to fair agreement. So their proposed definition, which I think is quite reasonable, is that you should see these small nodules of the liver both on H&E and reticulin staining, with this pattern of enlarged hepatocytes with a rim of smaller hepatocytes or thinner or atrophic liver plates and compression of the sinuses at the periphery. I think what's really important to take home from this case is that you should have perisinusoidal but not septal fibrosis. It's not cirrhosis, as the synonym might suggest. So NRH and vascular, the teaching points, I guess, is that these lesions are difficult to diagnose. But in a case such as this, when you're given a history of cirrhosis, for which they have good clinical evidence, but you don't see fibrosis, you should certainly consider it. And unfortunately, I couldn't find the example where I did this, but it's also important not to overcall NRH in cases of understandable established cirrhosis, as you can, of course, get some quite marked vascular remodeling in this. So thanks for staying with me. These last three cases, I'm just going to look at some of the special stains and ancillary studies in the liver, starting with pigments in the liver. So this is a fun case. Again, really not much in the way of history, of a 67-year-old man who came in for liver transplant with, I think, the highest bilirubin I've ever seen, up around the 700 mark. Macroscopically, there's clearly grossly cholestatic. No question, regarding the diagnosis of cirrhosis in this case. It's still important to look for interlobular bile ducts, even in cases of cirrhosis. What was really striking about this case was the presence of, in addition to marked cholestasis, this reddish brown pigment within the liver. Hemosiderin and lipofuscin are two of the more common pigments you see in the liver, of course. We also see bile and copper not infrequently. Dubin-Johnson is quite rare. This case is none of those. The pearl stain does stain a little bit of iron, but not that red-brown pigment, and the Orthene stain was completely negative. On polarization, the liver, in fact, showed an unusual property of yellow-red birefringence, shown again here. And I won't go into too much detail. As I said, this is a fun and interesting case of erythropoietic porphyria. If you haven't seen these classic Maltese cross-inclusions, this is a very nice example. The porphyrias are a really interesting group of disorders arising from defects in heme synthesis. And this particular type of porphyria, it's in the ferroketolase enzyme. And the principal manifestations are this extreme photosensitivity as well as hepatobiliary disease. And the damage to the liver in these patients is thought to be via cholestatic injury and oxidative stress. In this literature case, the liver was actually much darker than ours, with this black appearance. And it's in fact been postulated that with the extreme photosensitivity that some of these patients may have in fact, or some vampires may in fact have had this disease, which is of course nonsense. So in unusual cases of pigmentation, think about polarizing your pigment and also take photos immediately, because this pigment does fade in time. And this is just a photo of the patient in ICU. They actually have to operate under yellow lights to prevent tissue damage from the porphyrins being excited. So moving on to something much more common with this next case, this is another recipient, liver transplanted for alcohol on further history. Low power, you can see established cirrhosis with fat. And on higher power, you can see areas of quite dense pericellular fibrosis. It can sometimes be difficult to establish etiology and establish cirrhosis. Some of the features that are characteristic of various diseases may no longer be there. You may not, in fact, see any fat or ballooning in cases of alcoholic or non-alcoholic fatty liver disease. And you may also see a number of non-specific changes, including fat cholestasis, just representing a non-specific reaction of the liver to injury or end-stage liver disease. So important, as I said, to look carefully at your special stains. And you can see on the H&E, in fact, that in addition to the other changes they describe, there are a number of cytoplasmic globules present, showing, which are clearly seen on DIPAS, as well as alpha-1 antitrypsin immunohistochemistry. And they do show these rimmed vacuoles, which are very characteristic of alpha-1 antitrypsin. If that wasn't enough, there's also some iron in the liver. So we have changes consistent with alcoholic cirrhosis, which, as I said, can be tricky in end-stage liver, but I think we've got enough to corroborate this. Undiagnosed alpha-1 antitrypsin deficiency, which always makes me very happy when I pick something up that wasn't known about, by the hepatologist, and also some mild iron overload. So just briefly looking at iron metabolism, this is controlled by hepcidin, which blocks release of iron from hepatocytes, enterocytes and macrophages into the bloodstream. So at low levels, such as you see in anemia of chronic disease, hepcidin levels are increased, reducing iron absorption. And there are a number of diseases that, of course, decrease hepcidin production. That is to say, they increase iron absorption, including alcoholic liver disease, chronic hep C, and, of course, mutations, that is to say, genetic hemochromatosis, of which the more common variants are the C282Y and compound heterozygotes. An important point being that single mutations won't normally lead to disease unless there is another etiology, such as alcoholic liver disease. When should you report iron? I would say always, because even early treatment with venesection leads to a normal life expectancy in these patients, and the gastroenterologist can decide whether to do further testing. And certainly in Australia, once you diagnose an index case, cascade screening of family members is recommended. And as I said, it is treatable, and in fact the fibrosis has been shown to be reversible in some studies. And we grade iron using this 4-tiered system from Scheuer. Alpha-1 antitrypsin deficiency, very common, is the most common genetic cause of liver disease in children. In adults, the presentation is quite variable. There's no approved treatment apart from transplantation. And we see a number of these cases each year where the patient has cirrhosis from another cause, such as alcohol, with alpha-1 antitrypsin globules identified. And it has been described, or well described in the literature, that even a heterozygous state does increase the risk of developing liver cirrhosis. Couple of pitfalls: you can get accumulation of alpha-1 antitrypsin due to secretory block, or but these are typically zone 3. And of course, these two entities which remain on my pathology bucket list. So these last two cases are very quick, and I will be keeping to time. So I think, to summarise case 11, determining etiology in established cirrhosis is difficult, but do keep burnt out ASH or NASH in your mind, in the back of your mind, of cases that might be called cryptogenic cirrhosis. You should report any amount of iron present, and suggest genetic testing in the appropriate context. So two more quick cases. This case was sent, 20-year-old man, autoimmune hepatitis with mutation, biopsy to monitor disease activity. So these are the biopsies here, transjugular biopsies, which tend to look a bit fragmented. Like some of the preceding cases, quite marked portal tract inflammatory cell infiltrate with interface hepatitis, some lobular inflammation, and also quite striking perivenulitis. And I won't go into this in any detail, but this is in fact an example of a monogenic inflammatory disease. And autoimmune hepatitis is, likely represents, a sort of heterogeneous group of diseases, or as some of these genetic studies are starting to show. So mutations, in fact, have been described in over 20 genes encoding various proteins that regulate signaling by flow pro-inflammatory cytokines, such as interleukin-1. The important thing being that some of the therapies targeting these may be effective in many patients. And next-generation sequencing will undoubtedly identify some other rare monogenic inflammatory disorders. And then finally, this case is, I haven't found any examples in the literature, but again, just highlighting the importance of clinical history and the advances in genetic testing. So we told 38-year-old man, abnormal LFTs, and that he'd had a kidney transplant, which was for this rare disease caused cariomegalic interstitial nephritis. So this is a really rare disorder, which is an example of a ciliopathy that's inherited in an autosomal recessive manner and causes chronic kidney disease through chronic fibrosis and cyst development. And they do get this bizarre cariomegalic change in the tubular epithelium. They describe that 1/3 of their cases involved the liver and had no histology. But our case did, and it's linked to FAN1 mutations, which is part of the Fanconi anemia DNA damage response pathway. So this is the liver here. Again, looks close to normal at low power, but on higher power in the portal tracts, we did actually have these strange enlarged cells in keeping with cariomegalic change. So to summarise, in these medical liver biopsies, clinicopathological correlation is vital. It's rare to do a liver biopsy for no reason, particularly given the morbidity associated with the procedure. In the biopsies, of which I've shown you a few examples that look close to normal, it's important, I think, to look more carefully and chase down some more clinical history. And as we saw in those last few cases, genetics are certainly playing an increasing role, and I think will continue to play more of a role in this era of personalised medicine. And I think also our role of pathologists is changing. While grading and staging is still important, I think we will be increasingly asked to referee in some of these complex cases that I've shown you. So finally, I'd just like to thank all the members of my department at Prince Alfred Hospital, pictured here, and also the Pathcast for inviting me to speak today. I'll stop here, but please find my email address and Twitter address if you have any further questions. I think we perhaps have time for one or two now. So thanks again for your attention.
Thank you so much, Dr. McKenzie, for such an elaborate area of the cases, which is encompassing different entities in the liver, especially medical liver. Thanks so much. I have a few questions that I can see online. Minesh wants to know how you would differentiate IgG for liver disease from primary sclerosing cholangitis in a first liver biopsy in research poor lab.
So we do IgG and IgG for immunohistochemistry in some cases, particularly if they've queried it. And I'd have to look up the most recent criteria, but looking for, an increased absolute and relative number of plasma cells in the portal tracts. I think, again, the clinical context is vital. I've found it, they say, I think it's 70% of cases of PSC have UC. I must say in our practice, it's probably closer to 100% of case, most cases I would say have underlying inflammatory bowel disease as well. So important, I think, really to track down that history and also their serum IgG levels as well. I hope that answers that question.
So let me see, there's another question here. Sue Neelam has this question for you. Do you come across Indian childhood cirrhosis-like disease in Australia?
No, I've never seen a case, but I would love to see an example if anyone could send me one or post it on Twitter. But yeah, I've never seen a case here.
Right.
It's listed on the differential. As I say, it's listed on the differentials, but yeah, I've yet to see a case.
Right. So Dr. Satish Rao asks from India, when do you ask for RNA test for hepatitis C when the card test becomes negative?
Sorry, could you repeat that one?
The question is, when do you ask for RNA test for Hep C when the card test comes negative?
I'm not sure what you mean by the card test.
Yeah, I'm really not sure what's exactly the card test.
Sure. Our lab does hepatitis C quantitation on hepatitis C patients post treatment with the antiretrovirals. As histopathologists, we don't request it, but we do have that information available, in our laboratory system to see that the Hep C virus has, in fact, cleared. We used to have a lot of difficulty in our transplants distinguishing hepatitis C from acute rejection, but that problem has, pretty much, disappeared with the. In Australia, we have what's the word? The government provides access to all patients with hepatitis C, so they all have the opportunity to be treated. So I'm sorry, and maybe if you could send the question to me in an email, because I didn't quite understand what you meant. But yeah, we do quantitative RNA analysis in our lab, but don't do any immunohistochemistry. I don't think it's been shown to be useful.
The next question is from Jeremy, who wants to know specifically about case 3, that is seronegative autoimmune hepatitis that showed bile duct damage. Does that correlate with maybe Harbel's? Should that be part of whatever seronegative autoimmune hepatitis is?
So is the question that should the presence of duct damage be part of the diagnosis of seronegative autoimmune hepatitis? Is that the question?
Yeah. I think that.
Look, I think you can see a little bit of duct damage in both seronegative, seropositive autoimmune hepatitis. To my knowledge, it doesn't form part of the diagnostic criteria. I think it's a very difficult area, and I hope I didn't confuse anyone. But I think it's possible that it's there's some variants of autoimmune hepatitis we just don't know about or don't show conventional autoantibodies. But I think it's possibly more likely that a number of these actually represent unrecognised cases of drug-induced liver injury. But as I said, sometimes it's only through time or clinical course that we can be sure in some cases.
Right. The next question is from Minesh. Some drugs causing autoimmune hepatitis like reaction even after months and years. In that case, how to differentiate drug-induced autoimmune hepatitis from seronegative autoimmune hepatitis, and how to sign out the report?
So I guess some drugs, and I think nitrofurantoin might be an example, or methyldopa perhaps, can trigger an autoimmune hepatitis. I think if it's got the characteristic pattern of injury and they respond to steroids, then it's reasonable to make the diagnosis. I do tend to leave my reports a little bit open because, as I said, it's hard to tell, and the histology looks the same. So it is, or very, there aren't any sort of key distinguishing features from true autoimmune hepatitis and that triggered by a drug. So I think you can only be honest in your report and say these are the differential diagnoses. And as I said, certainly in our unit, they will often give steroids regardless. I guess the difference is in true autoimmune hepatitis, if you try to wean the patient off steroids, the disease will tend to recur. If it is due to a drug injury, it'll tend to not, won't recur. But it is complicated by the fact that some drugs, do trigger this pattern of injury, just as, some infections perhaps, trigger episodes of or trigger inflammatory bowel disease, just that complex interplay between, environmental, genetic, and host factors.
Thank you. The next question is from Ari Varasan, who compliments you for lovely teaching and also wants to know, what is the best use of serum electrophoresis in liver pathology?
I must say it's not. I think they use it for. I'm saying I'm very much an anatomical pathologist, so I do tend to leave a lot of these things to my pathology colleagues in other pathology disciplines. I think it's used for alpha-1 antitrypsin, but certainly, I guess the way we practice in Australia, we see the H&E in the immunohistochemistry. But these other tests are largely done outside our immediate laboratory. So sorry, I'm not sure that I can answer that question very usefully.
Right. The next question is from Shruds, who wants to know, for staging fibrosis in Hep C, which is the most commonly used staging system?
We use Shoya and Metavir most often in Australia. I've also seen people use Ishak. They're all quite, if you read through them, they're all quite, similar in what they look at. I think the most important thing really is to state in your report which system you're using. and that you and your hepatologist, are in agreement or happy with the system used. Just because different numbers in different systems can mean slightly different things. So as I said, I like Shoya and Metavir personally, or perhaps that's just what I got used to when I was training. But whatever you use, as long as you state which one you're using, I think that's fine. But certainly now we're finding with the treatment for Hep C and Hep B, and the use of fibroscans to assess fibrosis. I can't actually remember the last time I had a chronic hepatitis biopsy for staging. It's actually, in Australia anyway, quite rare now to get a biopsy done purely for that purpose. We're getting a lot more of these biopsies where they're, I guess, trying to sort out which factors amongst several are the leading cause of liver injury in a patient.
Thank you. The next question is from Shruti, who wants to know, on frozen section, apart from steatosis, what else needs to be commented on donor liver biopsy?
The main thing they're interested is the degree of fibrosis. You would, of course, comment on any other obvious abnormalities. Again, interestingly, and the practice varies greatly around the world, but when I was at this Banff meeting, our surgeons hardly ever actually send them for assessment, but certainly in some practices overseas they do. But I think, fat, fibrosis, any obvious inflammation, and of course tumours, but that's a different scenario. But we do get biopsies from time to time, if they think there's an undiagnosed malignancy in the patient. But I was surprised when I took part in that study just to see that the variation in the reporting of fat in donor liver biopsies. So important not to overcall it.
I think there's one similar question related, is from Tazel. The question is, what's the adequacy criteria for donors' liver biopsy assessment on frozen?
I think that the cutoff sort of proposed in the literature is more than I think about 30% steatosis. But they are now using or tending to use more marginal donors because of the shortage of organs. So they will take them up a bit higher, perhaps towards, I'd need to check the latest literature, but perhaps more towards 60%, just due to the shortage of donors. I'd be interested for feedback. How many people's transplant centres do these biopsies? Because as I said, they tend to make a sort of macroscopic assessment in our unit and decide whether or not to use the liver rather than sending it from frozen section. But practice does seem to vary greatly around the world.
Thank you so much, Dr. McKenzie. I think that's all the questions that probably we can answer now. And as Dr. McKenzie mentioned, that if any one of you have any other questions, you can reach out to her either through Twitter or through email, and she will be more than happy to answer your questions. And Dr. McKenzie, you would be very happy to know that you had several hundred viewers from across the world, and in fact, I could count at least 25 countries from so many different time zones, and people were here from, of course, Australia. It was great to see a lot of viewers from Australia who were still staying late at night. And we also had viewers from countries as far as Nepal, Tanzania, Bolivia, and a special shout out to Julio from Belize, whom I haven't seen before. Thank you so much, everyone, for joining in. And once again, thank you, Dr. McKenzie. And in fact, our next lecture is coming up on We have a GYN pathology lecture series that is starting on Thursday, that is May 21st, and we have another GYN lecture the next day on May 22nd. So the first one would be by Dr. Fabiola Medeiros from Cedars-Sinai on May 21st. That would be at 1 p.m. Eastern time. And on 22nd, we have another GYN pathology lecture from Dr. Carlos Paraharan from Canada. So hope to see you then. And as always, please follow and like our Facebook page and also subscribe to our YouTube channel, that is Patchcast. And thank you again, Dr. McKenzie, for this excellent discussion and your engagement with the viewers. Thanks so much.
And thank you too for involving me. I hope everyone enjoyed the lecture and look forward to hearing from you online soon. Thanks again.
Thank you.